Good morning and welcome to Health Talk here on AM 1270 and 96.5 FM KXBX. I'm Paul Thomas, and Bill Kearney is in the studio with us from Northlake Medical Pharmacy, and it's a brand new world out there today.
Boy, is it ever, Paul. I tell you.
Change is in the air.
I gave up about 10 o'clock, and I guess you gave up about 11 o'clock. It was pretty clear that it was rather entertaining to see the news media backtrack.
Oh man, nobody expected it.
No, and
nobody thought it would happen.
I told you earlier I was going to make my presentation today about the increase in Obamacare premiums, but I don't think that's going to be a big issue.
Well, what did Trump say? He's got three main objectives he's going after right away, and that's the NAFTA deal, the different trade deal, and then Obamacare.
Yep.
So,
and I think healthcare needs to be attacked. It's I went to a meeting Sunday on my day off in Santa Rosa, and it was with a bunch of community pharmacists in the Sonoma County area, and it was about the Death and Dying Act. And we had the executive director of hospice on here, and I'd like to get him on again, but it was talking about health care. And the last time we talked about end of life and the Aid and Dying Option Act, it was pretty clear how it was going to be approached in the state of California, because that bill was passed back last year, and then it went active in June of this year. But since California has become active in it, some things have changed that I really want to talk to hospice about and see if it's different in Lake County. Gary Johansson, which is works for St. Joseph's Hospital in Santa Rosa Memorial in Santa Rosa, which is a parochial hospital, and there's usually a conflict of interest there with aiding someone to die. But it's purely optional on whether a physician or a hospice or a group wants to do that. But they're finding, because of the high cost of medication on the formularies before of secobarbital and penobarbital, that's causing over $3,000 cost, and some insurances are paying for it and most of them are not. That it becomes very laborious as far as the risk involved financially to go ahead and do this. So they're experimenting with changing the formulas. I haven't talked to any local physicians about this, and there are people that are willing to go through the process, and I think that's fine. My only intent is mentioning this is just informing you that there are changes that have nothing to do with the law being changed, but the interpretation of the law through our huge amount of lawyers that we have in this state, and the interpretation of the California Medical Association as well. Some of those changes in interpreting is the route of administration, which is ingesting. Originally, you had to prepare your own cocktail. Now somebody can prepare that for you. If you can't swallow the medication in 4 minutes, you can, if you have a gastric tube, it can be inserted in through that gastric tube, which means that somebody like for ALS that doesn't have, that can't swallow, can still continue to take this. The time frame involved is still a deterrent in many people's ways when they decide, for example, it's about a 6-month process, or you have to have less than 6 months to live to get a physician to write you a prescription, and then have another physician consult, and they're changing. That's taking time, and that's still part of the law. And it's still an option to, even after you commit, to go through this process. There is an option, you can option out at any time, including the patient, as well as any part along the way. You can go so far as to get the medication and then not take it, or start the process and not finish the process. So there's lots of options that really need to be explained. I was in a meeting last Friday out at the Clear Lake Riviera, and it was a group of ladies from the Civic Club there. That was quite a large group, 65 women, I believe, or 64 that were there. And we did a lot of explaining about what community pharmacies do over and above being somebody involved in this end-of-life law, that other opportunities that we give you as far as being your local pharmacy. And one of the options is we've talked about many times on this radio show of doing a brown bag program, and that's a program where you bring in all your medications that you take and you put them in a bag or a box or whatever it takes. If it takes a railroad car, then I might have to go down the railroad tracks and pick it up, but go over all your medications, both over the counter and on prescription. You don't have to be a customer of ours. You can be getting your medication someplace else. Of course, we'd love to have you as a customer, and would not charge you for this service to go through your medications and see if there was any duplications from one physician might have written for it generically and another physician might have written for it by the brand name. And to identify those and find out if you're duplicating the medications, or you may not be just duplicating the medications as far as the identical medication, but you may be taking a different kind of non-steroidal anti-inflammatory and be taking ibuprofen and Aleve. One is ibuprofen, one is naproxen. Both of them do the same thing. If you take them together, they're going to be less effective than taking them by themselves. So to look at the medications and identify them and look and see if you're currently taking the medications properly. Lots of people that I've done this for are taking a lot of supplements. Whether those supplements are necessary or not is something that you and your physician have to determine. I can look at your lab results, for example, or look at the medications that you're taking that are on prescription and tell you whether or not I feel like you need to take those supplements or not. However, whether or not I decide that it's not necessary or not has nothing to do with whether if evaluating those medications can actually make you feel better and I see that they're doing no harm to you, then I'm not going to recommend that you quit those unless you have to. There are some medications that you probably don't need, but I'm not God. I'm not the person that can decide that or not, and neither can your physician unless there's an interaction with the prescription medication that you're taking. So it's a free option. I have to go out of town for the next 4 days because I have a sister that's ill in the Midwest. But I'll be back after that, and we can set up an appointment and just call and say you were listening to me on the radio and you want to come in and evaluate your medications, and they may ask you if you're a patient of ours, but it doesn't make any difference whether you are or not. We'll be more than happy to go through that process. And each time we do that, hopefully we can give you some assurance on what you're taking. I just had a person that was at that conference on Friday come in on Monday, and we went over her medications for her, and she was taking many supplements, and one of the ones that she was taking was probably a higher dose than she really needed to take, but when I evaluated that medication, I said, that's entirely up to you. You may have side effects from taking it at that dose, and it's probably not any more effective, but it's certainly not contraindicated, meaning there's nothing that says you can't take that. But some of these supplements are expensive. Most of them are not, but some of them are. And maybe that product would have lasted you twice as long if you didn't take twice the dose. But you can look it up on the internet, and that's one of the things that we kind of caution people about, is if they are looking it up on the internet, look at a website that's a health website like WebMD or Mayo Clinic or Health Central, the one with Dr. Dina Dell. Those are CNN Health. Those are all websites that have experts that will answer those questions for you, or give us a call at the pharmacy, and and we'll be able to at least give you some guidance. So I just wanted to remind you that that's one of the things that we do as an independent pharmacist, and are more than happy to give you that service at no cost to you. I'll put this one aside that says sharp rise in Obama healthcare premiums for 2017. I think due to the election, you've all been made aware. And one of the processes, one of the reasons is that Obamacare seemed like a good thing, is they assumed that younger people would buy Obamacare. The difficulty in that is most young people with young families don't spend a lot of money on health care because they're young. They have a child or two. Usually they're not severely ill, so the majority of the population of young families aren't receptive to paying high premiums for health care. And the assumption was by, I think this was entirely, I'm not choosing sides here, but there wasn't one Republican that signed that bill. It was all Democrats, and it was that's why it was called Obamacare. And it had some very good options in it that were that will probably be kept when they reevaluate Obamacare. One is that you would be able to be covered under your parents' insurance till you're age 24 or 26. That underlying conditions would not prevent you from getting health care. But the problem is the younger people didn't buy the insurance, so they had to be subsidized by the states. Well, the states went broke on their provision to provide Obamacare, like California, what is it called? California?
Covered California.
Covered California. They couldn't afford it either, and once the government took the subsidy away, they were subject to paying for the whole thing. So the only way they could pay for it is to increase your premiums and increase your deductibles. I just signed a contract for my employees that I pay for their health care insurance every year, except their deductibles and their co-pays, and it had gone up 17%. I had to evaluate whether I wanted to put more of a financial obligation on my employees by making them pay a higher deductible and a higher copay, or if I wanted to absorb that. I took the opportunity to stay the same and let my employees not have to forfeit the extra 17%. I'm one of the few employers in Lake County that does this for my employees. But that's why we're still in business after almost 37 years. So I don't like the fact that you have fewer choices. I don't like the fact that you have a preferred provider where you have to go to one of the providers. I did find out, one thing I reported to this group last Friday was that Anthem was one of the ones that had what they call an EPO, and that EPO was for people under the age of 65, and it covered Sutter in Lake County, but it didn't cover Sutter in Sonoma County. Now, I don't know if it went beyond that and covered Sutter down at CPMC and in the Bay Area, because many people have to go there for procedures. But if you're over 65, you don't have that EPO. It's called a PPO, and a preferred provider offering, and it will be covered. So what I suggested to the audience there was check with your insurance advisor and see if your particular plan, if your providers are here in Lake County, or you have to go to some other county in order to get services. And that's the case sometimes in dental plans also. So it's something you really need to check on.
Hey, Bill, I got a question for you.
Yes. Mhm.
Where do you think, with the, obviously Trump, one of his priorities is to drop Obamacare. So for the people that are covered under that, where will they then go? Will they still be stayed in kept in a system that will be reformed, or do you think it's going to be wiped out completely and they'll have to seek health care elsewhere?
Well, it would be a big mistake for them to eliminate all phases of that. And I think if, of course, I'm not running the government, but if they're smart, they may go to a single-payer system. They may open it up for competitive bids but they have to, someplace along the way, there has to be some ceilings on what they do.
Mm-hmm.
I would not think that it would be appropriate or it would lack a lot of intelligence to just discontinue Obamacare without no coverage. There's too many millions of people that have it.
Yeah.
So there would be some option in between. I don't think anybody will go without insurance. This is also new. I don't think the majority of the population expected this to take place. But they all went to the polls and decided that they wanted to change in government. And
Yes,
I don't think it meant anything about Democrats or Republicans. It had to do with government per se. Instead of it becoming a government by the government and for the government, they want it by the people and for the people. And that's where it has to change. When you see politicians run for one term of office as a representative for the state of California, and they get $174,000 a year for life, and their wives are insured, and they are insured under the federal employees health plan, and they just have to run for one term, and they get it the rest of their life. Something has to change. You talk to your congressman, which Mike Thompson is our congressman, and I will talk to his office, and I'll say, look, and I know there are a lot of Mike Thompson fans out there, and Brad Honorado is a good friend of mine, but Senator Thompson or Congressman Thompson has not helped me when it's come to issues that I needed to be addressed as far as the federal government's involvement. But when I talked to his office in Washington, D.C. about having the same health care plan as we have, they don't want to talk to me because they're covered under their federal employees insurance. That's not just Congressman Thompson's office. That's every congressman's office and every senator's office and every federal employee's office. It's like Proposition 61, which was a state of California proposition that said vote yes on this, and that will keep you from having drug companies raise the cost of drugs paid for by the state of California under the veterans cost. That was not correct. It's only involved with drugs the state of California pays for, which was 12% of the California population. 88% of us it wasn't affected by in the least. And I had several veterans call me at the office in the last few days asking me what I would do, and I told them as a veteran I thought it would be nuts for them to raise the price of the cost of drugs to TRICARE or to the federal government or the state government, because veterans are such a high profile now that we better treat the veterans with respect. So that decision was defeated. 61 was defeated, and I think that was a good thing. We never know when it comes to politics. When you read the propositions, they're worded to sound like they want you to vote for them or vote however it's written, and you really can't make head nor tails. And there was no cost involvement with this particular proposition. They couldn't determine how much it would cost the state. They couldn't determine how much it would save the state. So without real figures in there, it was impossible to tell whether or not it was a good or a bad decision. So, but on past the election, we're looking at. I looked at the New York Times last night because I heard the New Yorker magazine had a magazine on the shelf that said had Trump's picture on it, and it had "loser" pasted all over
Wow.
the front of it, and it went on the stands last night. So I saw that in the
You
New York.
saw that? Wow, they
It
already.
was on the New York Times. I don't know if they pulled it before they distributed it. But when I was looking at the Times, I saw an article that said a doctor shortage, and it said, let's take a closer look. And as we have talked about many times, many people have to wait too long to see a doctor, and it's getting worse, and especially in rural areas like Northern California. If, as many people believe, we have a shortage of doctors in the United States, then it follows we could fix this by training and hiring more physicians. But as about everything else is with healthcare, it's complicated. Some people think there's not a shortage at all, just a poor distribution of the doctors we have. The main argument is that we aren't adding enough new doctors to keep up with the demographics. And the Association of Medical Colleges has projected by 2025 there will be a shortfall of between 46,000 and 90,000 doctors in primary care. It's a shortfall of between 12,000 and 31,000 doctors. One thing we didn't project is the baby boomers are getting older and they're sicker and they have more complex conditions. I asked at this meeting on Friday afternoon, I said, raise up your hands if you're taking prescription medications. 75% of the people in the room raised up their hands. Mm-hmm. The second question was, raise up your hands if you're taking more than one medication. The same 75%. So that means as we get older, not only are we living longer, but we're getting, more people are getting arthritis and high blood pressure and pulmonary disease and diabetes and cancer. The Affordable Care Act is expected to accelerate the need for additional medical care, which they hadn't really anticipated. Obamacare alone, which is still on the books, is projected to require about 16 to 17,000 more physicians than they would have required if we didn't have that. And that's why I say, Paul, that they're not going to abandon that completely, because just that alone is going to require 16 to 17,000. And if you add more to this argument, the United States has fewer practicing physicians per 1,000 people than 23 of 28 countries that reported the data in 2013. The United States has 2.56 doctors per 1,000 people, which is more than Canada or Poland or South Korea, Mexico, but we're way behind countries like Austria, Norway, Sweden, Germany, and Switzerland, which have excellent medical care. Based on that data, it would seem like we need more physicians. It would also seem like we're not training them. When it comes to medical graduates, the United States ranks 30th of 35 countries. We used to be the most fantastic, give the most fantastic health care of any country in the world. But there is strong evidence that we're thinking about this the wrong way. A thorough analysis on the graduate medical education that argued there was no doctor shortage and that we really didn't need to invest more in physicians is way undermanned, and it's very inefficient. We rely too heavily on physicians, maybe, and not enough on mid-level practitioners. But in a place like Lake County, where there's fewer and fewer physicians practicing now, it's all mid-level people, and we don't account for technology like telecommunications. We fail to recognize that we really have distribution problems. Parts of this country have way too many doctors, especially in the cities, where it's most desirable for the doctors to live. And then it's made worse by the way we reimburse for Medicare. For example, we pay doctors more who live in places that are more expensive. So a doctor that's in San Francisco practicing gets a lot more money than one in Sonoma or Lake County. The argument, of course, is that the cost of living is higher and that reimbursements must be too. But that also means that doctors can earn more in places where they already might want to live, and as a result, in many rural areas and less popular cities, we are experiencing what we are here, and we're having doctor shortages. a lot more than others. And then the distribution is also due to specialization, because a specialist gets more money than a family practitioner. But in areas like Lake County, we need more and more family practitioners. There's an important fact about the American healthcare system, and we sometimes hear that we have too many specialists and few generalists. I just talked to somebody yesterday who saw a hospitalist in a hospital that wasn't in Lake County. They were not on the preferred provider list, and so they had to pay $500 to have a hospitalist walk in and say, "You're okay," and leave the room because the insurance wouldn't pay for it. That's where these financial drivers play a role. Doctors who choose to specialize can make much more money, millions more dollars a year than a primary care physician. And of course, there's a huge amount of debt. When I talked to people Friday, I told them that it's anywhere from $250,000 excuse me, dollars up to $500,000. And this article in the New York Times said the average student for somebody finishing medical school in 2015 was $180,000, and that comes from areas not like California. If you go, it costs about $40,000 a year to become a pharmacist in California at University of Pacific. In University of Missouri, in the state of Missouri, it takes about $4,000 a year. So 12% of those graduates have debt that equals more than $300,000. The median starting salary for a resident physician, and some of these residencies go for 5 to 7 years, is $52,000 a year. So by the time you're in your 30s, you're $100,000 in the hole. And the more residencies you take and the more internships you do, the farther behind that you get. And, you know, that I don't want you to feel sorry for physicians because they don't make a lot of money, because they do. They're more likely to be in the top 1% of earners than almost any other profession. But it's important to recognize that these drivers are at play and that they do make a difference in whether or not we're getting physicians. So what no one seems to be debating is that we do have a shortage of services. We could fix that by increasing the number of physicians, either by training or allowing more to immigrate into the country. I, for one, am not disagreeing that we need more physicians, and I don't know that it can be fixed by purely bringing more physicians in if they don't go into rural care or generalist practice or family practitioners. So, and changes in that training has to take place. We could fix that by making the healthcare field more efficient. That's what we're going to try to do by fixing Obamacare. But it's an issue that we really need to look at, we really need to think about. And as you go in to try to find a physician in Lake County, you're going to see more and more of that take place. I'm not degrading physician's assistants or nurse practitioners. I think we have many, many very qualified. But when you get into a situation where your health is really in danger and you need the expertise of a physician to analyze that, you need to make sure that you're the one that's progressive in asking for that, because you have to be the overseer of your health. No one else is going to do it. We're going to take a break. When we come back, we're going to talk how a stroke and a heart attack differ. Hi, I'm Bill Kearney from Northlake Medical Pharmacies, and recently I spent some time with some of the students in Mrs. Goodwin's third grade class at Lakeport Elementary School to discuss the importance of taking vitamins. I asked the students, why is it important to take your vitamins, and here's what they had to say.
They give us lots of energy. They help us learn. They're good for our bones. They're good for our bodies.
They keep us from getting sick. They're good for our eyes.
They're good for our brains.
They give us shiny hair.
They help us sleep better.
Northlake Medical Pharmacy, a good neighbor pharmacy, is offering a Healthy Kids free vitamin program to the kids of Lake County. Any child aged 2 to 12 can receive a free 30-day supply of children's chewable multivitamins every month for a year. Simply sign up your children at either of our 2 locations at 347 Lakeport Boulevard in front of the Bruno's Shop Smart. Call 263-1328 or at 5136 Hill Road East across from Sutter Lakeside Hospital. Call 263-6192. The Healthy Kids free vitamin program at Northlake Medical Pharmacies.
They're good for us.
I'm Dr. Jackie Duncan. When my daughter asked me to come to her school to talk about my job, I wasn't sure if clinician scientists would be very interesting to her classmates. But when I told them that my research might prevent their grandparents from losing their sight, that got their attention. I'm working with the American Health Assistance Foundation to find a cure for macular degeneration, a debilitating eye disease. Macular degeneration is a leading cause of vision loss for people over 60, affecting over 11 million Americans. It's important to let young people know how to take care of their sight. I told the children about ahaf.org/kids, a website created just for them. Here, families learn about the disease using interactive games, stories, and other activities. Visit ahaf.org/kids or call 1-800-437-2423 for free information about macular degeneration. That's ahaf.org/kids or call 1-800-437-2423 for free information and resources.
On today's episode of America's Least Wanted, the home invaders most likely to threaten your family are not human. Cockroaches can spread salmonella and trigger asthma attacks. Termites destroy billions of dollars in property each year. And stinging insects send 500,000 people to emergency rooms. Learn how to protect your family. Arm yourself with the facts at pestworld.org. A public service announcement from the National Pest Management Association.
Hi, I'm Mia Hamm. As a professional soccer player and a future soccer mom, I know how fun and rewarding sports can be. I also know how frustrating it is when you're sidelined by an injury. So I've teamed up with the American Association of Orthodontists to ask young athletes to play it safe when playing sports. I spent years training to become a world-class athlete. I know what it takes to become an expert on the field. Orthodontists understand this too. They're experts in their field, helping kids and adults obtain healthy, beautiful smiles. They want to help athletes prevent injuries and stay in the game. It only takes a second to get hurt, and too many athletes are risking injury because they're not properly equipped during games and practices. Wear the right protective gear, like mouth guards, face masks, and helmets. Your first line of defense against preventable injuries. Play it safe, achieve your goals, and keep smiling. Visit braces.org.
All right, we're back.
We are back, and I'm going to go through just a few short issues before we get into heart attack versus stroke. One thing that came out last week was about antibiotics. They're looking at a lot shorter terms for antibiotics than they have in the past. Instead of having these 5 and 10 days, and I think I briefly covered this last week, that maybe on a urinary tract infection, that 3 days is enough for an antibiotic because people are building up resistance to these antibiotics by taking them 5 or 10 days. When it becomes pneumonia or something like that and it's a 10-day therapy, they suggest you continue on the 10-day therapy. But there's a lot of days where a lot of 10-day treatments for skin infections and those kind of things can be limited to 5 days. So, for example, there's 5 days of antibiotics can be given instead of 10 to 14 days for many uncomplicated skin or other kinds of diseases that aren't really elaborate as far as the extent they are. So you will see practitioners write for less antibiotics, and in the past we would lecture you, even if you feel better after 5 days, to continue to take in it for 10 so your body will build up the immunity. That doesn't always happen, doesn't necessarily, your body is more resilient than they thought in the past. So just be aware that you may see a shortening, and if you have to get a refill, then of course we can always refill with the doctor's okay, which we never did before. Acetaminophen and codeine, Tylenol and codeine, they're starting to recommend that the FDA is thinking of saying that nobody under 18, all children under the age of 18 for any reason, shouldn't be given Tylenol and codeine. I just had it's because that they can get a respiratory problem, a breathing problem if they're over-sedated. That was very difficult for me filling a prescription yesterday for a 10-year-old child, and I told the father, I said, the FDA is going to recommend that nobody under the age of 18 take this. The child was of substantial weight enough that he was probably okay doing that, and I didn't want to go against the physician, but I did caution him to be aware, and it was so much every 4 hours is needed for pain, and he had some teeth pulled. So I said he's going to probably need it for a while, but you're going to see a reluctance in parents to accept that. But it's the move by the federal government to curb the use of narcotics in many situations. Another thing was about whether or not it's okay to take aspirin to reduce cardiovascular risk if you have GI bleeding. If you've had a cardiovascular event before, like a stroke or a heart attack, it's fine to take 81 milligrams of aspirin. If you haven't, on the other hand, they would suggest if you don't have a high risk, such as blood pressure or anything like that, or you're taking a statin, don't be surprised to see patients not take it after 3 days after they've had a GI bleed. But people that are taking aspirin with food or use an enteric coated product to limit the upset stomach, that has been acceptable. Sometimes using a PPI, which is a proton pump inhibitor like omeprazole, will keep the acid down, but you'll see them question it or use preventative measures, as many of you are on right now, to keep from having a GI bleed if you've had one in the past. A GI bleed is what we call bleeding in the stomach. Used to be strictly from an ulcer. Now it can be from just thinning out the lining in the gastrointestinal tract, in the intestines and the stomach, from just excessive use of non-steroidal anti-inflammatories, of which aspirin is one. But when you've had a CV event, cardiovascular event, and you're already recovering from a stroke or high blood pressure or a heart attack, and you've already had a GI bleed, then they're going to probably put you still on a low-grade aspirin, but put something on that protects your stomach as well. So you're at high risk for GI bleeds after you've had one, but you're at high risk for a stroke or a heart attack if you've already had one too, and we want to keep that separate. So a lot of people have questions about a heart attack and a stroke and how to tell the difference. A heart attack that we hear about all the time is usually when the blood flow to the coronary artery, which is the main artery that goes into the heart, is reduced or blocked. And what do we mean about reduced? You've heard me use the example of when you put your hand around, a fist around a garden hose, and you squeeze the garden hose and the diameter is smaller, it makes the flow of the water be reduced. The same thing happens in your circulatory system when you get a buildup of plaque. And plaque is why we put you on statins for high cholesterol, because high cholesterol is cholesterol that gets too high and it occludes or sticks to the inside of your blood vessel. When that happens, the diameter becomes smaller. As it becomes smaller and smaller, if we don't do anything about getting rid of that high cholesterol or plaque, then eventually your blood vessel stops, and then it doesn't supply blood to the heart, and that heart muscle without blood flow can become narrow due to the buildup of those substances, including fat and cholesterol. The plaque usually occurs over several years. If a plaque is in a heart artery, a blood clot forms around that, and then the formation can obstruct the blood flow to the heart muscle. So as a result, the heart muscle doesn't get enough oxygen, and then that part begins to die. And that sounds rather drastic, but it's true in so many cases. If it's not treated quickly, the scar tissue begins to replace the heart tissue, and then due to lack of oxygen and the nutrients, it results in a block. A stroke is completely different, and that's when the supply of blood to the brain, not the heart, is interrupted, and it's reduced or blocked, and that deprives the brain tissue of oxygen and other nutrients, and that blood vessel carries oxygen. That's why sometimes when you take a medication that dilates the blood vessels, and it could be to help the pain in your legs, or it could be to help that you have a flow with, or a problem with urinary tract flow, and it opens up those blood vessels so you can urinate better. But sometimes when you stand up quickly, that blood drops to your toes. Well, what happens then is you get a little dizzy. Well, what happens when you have a stroke is you get a little dizzy, only that dizziness doesn't go away. That blood vessel that carries oxygen either bursts or is blocked by a clot. And any brain cells that are deprived of oxygen begin to die. And that sudden death can happen within minutes. You've heard people that were completely healthy, were runners, that exercised all the time, ate the right kind of foods. We would do an angiogram and look inside their blood vessels, and they're completely clear. But we don't necessarily do electroencephalogram where we look in their brain, or we don't look for an aneurysm, which is above that blood vessel. So any brain cells that are deprived start to die. That sudden death happens. If you're lucky, you have what they call a TIA, which is a mini stroke. And it's caused by a temporary clot, and then it goes away. That's a warning that you've got a problem. And so you need to make sure you inform your family practitioner or your cardiologist when something like that happens. Now we go back to the heart attack because the symptoms are different. The most common symptoms of a heart attack are chest pain. You've heard people are taking nitroglycerin to envelop and increase the diameter of the arteries around the heart. That chest pain occurs when the heart is trying to pump blood into the heart, and those blood vessels are smaller. So instead of it going directly into the heart, it starts backing up into your chest in those smaller arteries, and that's called angina or chest pain. And that's because the diameter of those blood vessels are smaller now, and the heart has to work harder to get the blood through. That also cause an upper body discomfort, like your whole chest area is becoming inflamed. It may be so severe that you're getting shortness of breath because those blood vessels carry oxygen to the heart as well, and to the respiratory tract, to the lungs, and tired, and nausea, lightheaded. So these things can vary from person to person. So some people have none, some people have mild symptoms, some people have that TIA, which is like a silent heart attack. Stroke victims are different because the symptoms depend on the part of the brain that is damaged. They can have a number of problems, including memory and speech, muscle control and function. Many times you'll see somebody sitting in a chair and just staring, and they try to communicate and they can't. Sudden numbness or weakness in the face, arm, or leg, which seems to occur more on one side of the body. Confusion of trying to speak or understanding speech, and sometimes that goes away and then they start talking normally. They might have a sudden difficulty in walking, or dizziness or loss of balance. They might have a problem seeing out of one or both eyes, and sometimes they can get a really severe headache, which could include vomiting and dizziness, or an altered form of consciousness where you're coming and going as far as your consciousness goes. We know what the risk factors are with heart attack. We talk about it all the time. Smoking, high blood pressure, high cholesterol, being overweight, diabetes. Why diabetes? The same thing is happening to your blood vessels and your nerve endings, the diameter is becoming smaller because too much sugar is causing too much cholesterol to accumulate. Of course, we always talk about diet and exercise, lack of physical activity, drug and alcohol abuse. Those are common ones, and then you add hereditary factors to this that you can't do anything about. You could have high cholesterol because it's inherited. You need to be on medication, and most of the time the medication works even though you don't feel like you need it because you're eating healthy and you're getting exercise, but that isn't enough to do it. All of these together will help combine making those risk factors seem less important as individuals and more important collectively. They could have similar medical conditions and symptoms of a heart attack and a stroke. The angina, which is what we talked about with the coronary artery disease, that's the chest pain or discomfort due to heart muscles not getting enough blood. Sometimes that can feel like just pressure and not having any pain. You know, you heard me talk about aneurysm before. An aneurysm is an enlargement that can burst or tear in the aorta. The aorta is that big artery that goes into the heart. And you remember me saying if you look at an angiogram, you go in and look to see if there's a clot in there. You can't see it, but there's a bubble up above that blood vessel that you can't see because you're looking for the clearness of that blood vessel. And so you don't know it's there. And then that's why we found out that many times statins were very effective in lowering the amount of aneurysms that we saw because it's an anti-inflammatory as well as a cholesterol-lowering drug, and it keeps the inflammation down so that aneurysm doesn't occur. Arrhythmia, I can't tell you how many people that were diagnosed now that weren't diagnosed in the past with having an arrhythmia. That's an irregular or unusually fast or slow heartbeat. It's not always detectable unless you're tested for it. The heart is designed to pump the same amount of oxygen and blood into the heart and out of the heart on a regular basis. That's why when a physician or a physician's assistant or a nurse practitioner listens to your heart, you hear that thump, 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 thump. That's the heart opening and closing. Sometimes you don't hear that regular heartbeat. You hear an irregular, and it'll go thump, 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 or some version of that. And it'll be sporadic. It won't always be in time. That means you have a condition, excuse me, that's called atrial fibrillation, which can cause a stroke. And that's not always detectable. You can do an echocardiogram many times and a stress test and look and see that, but it doesn't just show up always when they're taking your blood pressure because sometimes it's not distinct enough. Severe heartburn or acid reflux can also feel like a heart attack. I've told this many times on this show. When I first came here in 1980, I was running the pharmacy by myself. Didn't have a relief pharmacist, didn't even have a clerk, didn't have a technician, didn't have any business. But I was opening the pharmacy, filling 5 or 6 prescriptions a day, and I couldn't right across the street from the hospital, and I kept getting this burning like angina. And I didn't go see my physician, who happened to be an internist, because I was afraid he'd tell me that I was having angina and I was going to have a heart attack. Now, this is how smart you are, you know, when you're, you see, that was almost 40 years ago. I was 40 years old, you know, so, or 35. And I said, well, I'm just going to keep working. Well, finally, the risk was too high, and I went to see him, and he says, your heart's perfectly fine. He says, I think what you have is acid reflux. Put me on, we didn't have the PPIs at that time. We had acid blockers like Tagamet and Pepcid and Zantac. Put me on one of those. It completely disappeared. And away went my depression, away went my anxiety, away went my thinking that I had a heart attack. But that's also your symptoms of having a heart attack can have those kind of effects also. And those other telltale signs of stroke sometimes are migraines, seizures that can prevent similar symptoms, brain tumors. A mass present on the brain tissue can do the same thing where it cause you to have a stroke. I have a sister that got shingles 5 years ago. She got it in her eye, her right eye, and now she has Bell's palsy. It acts just exactly like a stroke. It's a condition caused by damage to the nerves on the brain tissue. So loss of feeling in the arms and legs or problem walking. She still has the visual signs of that, and she can't get rid of the herpes virus enough to get a shingles shot. So that's another one of those things. So the treatments for both of these things is a lot more severe for stroke because you have a lot of permanent possibilities of permanent paralysis, permanent speech, but physical therapy can help a lot. With a heart attack, it's you can give anti-inflammatories for the chest pain. You can have procedures and surgery. You can make heart-healthy changes, cardiac rehabilitation, a lot more difficult when you have a stroke. In the few minutes that we have left, I want to advise you that it's time to get your flu shot. We have a pharmacist at both pharmacies that you can walk in and get your flu shot. If you haven't had both pneumonia shots and you're over 60 years of old or 65, you can get your second pneumonia shot. If you haven't had either one, you can get one. We can give it to you at the same time as we give you the flu shot. We can't give you both a pneumonia shot and a Zostavax shot at the same time because they're both live vaccines. But you can get a flu shot and a pneumonia shot or a tetanus shot if you need it. We give up to 25 different immunizations, and you don't need a prescription to come to us and get a shot. But it's really time to get your flu shot. I'm starting to travel this week, and I'm going to make sure that I'm covered before I leave for the Midwest. I'd like to remind you that we're Northlake Medical Pharmacy with 2 locations for you at 5136 Hill Road East across from Sutter Lakeside Hospital. Call us there at 263-6192. And outside the Bruno Shop Smart at 347 Lakeport Boulevard, give us a call there at 263-1328. Thank you, Paul.
Thanks, Bill. See everybody back here again next Wednesday for Health Talk on AM 1270 and 96.5 FM, KXBX Lakeport.